Good morning. Thank you all for being here today. My name is Hannah. I'm a medical student at Harvard, and today I'm going to be speaking on the relationship between pediatric isotretinoin treatment and adult body height in acne patients. To start off with some background, as many of you likely know, isotretinoin is an oral retinoid used in the treatment of severe acne vulgaris. This figure shows ways that retinoic acid is thought to impact puberty, acne, and then growth plate maturation. So starting off in puberty, you see a rise in growth hormone and insulin-like growth factor 1, and retinoic acid is thought to interfere with this. And then going on to acne, there are a myriad of ways that retinoic acid is thought to impact acne pathogenesis, including inflammation, C. acnes proliferation, and sebum production, sebocyte growth and proliferation. And then finally, both the hormonal changes of puberty as well as retinoic acid specifically are thought to affect growth plate maturation. So given this, we have also seen in the research effects of retinoids on growth and growth plates in both animal models and human case reports. So in animal studies, we've seen induction of epiphyseal plate degeneration and irreversible epiphyseal plate closure in animals treated with retinoids. And then in the literature on human patients, we've seen premature epiphyseal closure in patients treated with isotretinoin at a range of doses as low as 0.5 mg/kg per day over a time course of months to years for various indications. And then this figure shows the range of ways that oral isotretinoin is thought to affect growth. In addition to the hormonal effects that we've talked about before, these are the ways that it is thought to affect growth plate and potentially lead to premature epiphyseal closure. So given this research, there's this open question of whether patients being treated with isotretinoin for acne during pediatric age ranges are more likely to experience premature epiphyseal closure and as a result shorter adult height than their peers. So our research aimed to investigate the relationship between pediatric isotretinoin use in acne patients and their final adult height using a retrospective cohort approach. So the data that we used for this came from the TriNetX Research Network, which contains electronic medical record data. At the time that we did this research, we did this analysis on March 27th. There were approximately 143 million patients in 101 healthcare organizations accessible through this database. And the criteria for the patients that we included, they had to be at least 21 years old with a height available at least 21 to represent their final adult height. They needed to have an acne vulgaris diagnosis, and then the patients treated with isotretinoin needed at least 2 instances of isotretinoin in their medical record between 3 weeks and 4 months apart. Control cohorts with treatment of doxycycline, which, as discussed, is also used in the treatment of acne, and they could not be treated with isotretinoin. So to discuss what age range we wanted to focus on, we thought about when patients were, how to capture as many patients as possible who were unlikely to have stopped growing by time they had started on either isotretinoin or doxycycline. So based on the literature and our primary analysis, we looked at males who were 17 years or younger at the time of treatment, and then females who were 15 years old or younger. And we separated by sex, and we also conducted secondary analyses restricting to younger ages at treatment to see if this relationship was changed in those settings. The cohorts and controls were propensity score matched at the age that we did, at the time that we did the analysis, age when they were first treated, as well as race and ethnicity, and we compared the mean of the most recent height in these groups. So these are the demographics of the patients that we included. So in our primary male group, we had over 2,000 patients in each the cohort and the control. And then in our primary female group, we had 641 patients in the isotretinoin-treated cohort and in the control. And then these are the results for the mean heights in each of the cohorts that we looked at. As you can see, only one of the comparisons was statistically significant, and that was the primary male, so all males treated under 17 or younger. And in fact, in this group, the males were actually treated with isotretinoin were actually statistically significantly greater mean height than the control group, and then in none of the other comparisons was the result statistically significant. Here are these results represented visually. So at the bottom are the different groups that we looked at, and then their mean heights with error bars representing standard error. On the left in red is the isotretinoin in each comparison, and then the right in blue is the doxycycline. Again, this was the only statistically significant comparison where you can see on the left the isotretinoin having a taller mean height than the control. So to summarize, our only statistically significant finding was the male isotretinoin treated cohort in our primary analysis having a statistically significantly greater mean height than control. No other comparisons were statistically significant. We also looked at the amount of patients who were shorter than 2 standard deviations below the mean and found similar proportions of individuals shorter than 2 standard deviations below the mean across all cohorts. So these findings were ultimately reassuring against an association between pediatric isotretinoin treatment and stunted growth among acne patients. And then even in the cases where there was no statistically significant difference, the greatest difference between mean heights in any analysis was 0.33 inches, which is likely not a clinically significant difference in adult height for many acne patients. The strengths of this research include that it had a relatively large sample size thanks to the TriNetX database. Limitations include that we were unable to evaluate the effects of cumulative isotretinoin dose, as well as once we restricted to those younger ages at time of treatment, the numbers of patients were smaller to the point that we had relatively imprecise estimates for some of these secondary analyses limited to our younger age groups. So in conclusion, we have reassuring evidence that pediatric isotretinoin use for acne is not associated with stunted growth, which can inform treatment recommendations and shared decision-making around isotretinoin use in the pediatric population. Future directions for this research would be to look at effects of cumulative isotretinoin dose. As I mentioned, that was something we weren't able to do in this project. And another potential step would be to conduct prospective analysis to answer this question as well. I would like to acknowledge my wonderful mentors, Dr. Lisa Shen of Boston University and Boston Medical Center, as well as Dr. John Barbieri of Brigham and Women's Hospital, as well as the statisticians of Boston University who provided the statistical support with this project as well.